EBP presentation. So our research question was, what can SLPs do to improve patient-provider communication in medical settings for adults with complex communication needs, and how can AAC influence these communication interactions? So this is a little bit about how we found information on our topic. You can see some of the search terms that we use and the amount of hits. So in quotations, those are kind of some of the things that we searched to find our articles. So AAC in communication with medical providers, AAC in patient-provider communication, and AAC communication interactions medical. And then you can see that we kind of got a decent amount of hits, which was helpful.
Okay, the populations and settings we studied, we looked at adults with different brain injuries, aphasia, learning disorders, they say it there. We also looked at nurses, care, so like the family members, in different medical settings, long-term, rehab, acute. And we didn't have any specific treatments used for our research. And the type of studies that were used, we had systemic reviews, qualitative studies, and one article was a qualitative using the methodology interpretive description. And how were they measured? Participant observations, focus groups, interviews, systematically review research regarding communication between nurses and patients with complex communication needs. And one of them was measured through data triangulated through crystallization, peer review, and member check.
So we looked at 7 different articles, and across all these articles, we found a few different themes. So we organized our themes by color, and there are 6. So first, we're going to talk about the blue theme, which was strategies to help patients communicate. So in Article 1, this talked about a few different things. So first, it talked about general strategies to provide patients in medical settings with communication access. So this includes things like plain language, using speech-generating devices, communication partner training, and comprehension checks. This article also talked about how AAC professionals can address communication barriers. So some strategies that talked about were teaching medical students or professionals about this communication, hiring a full-time SLP, and providing AAC strategies and technologies to patients. Article 1 also talked about how it is important to prepare individuals for future medical encounters. So some strategies for this can be medical passports, having information ready to describe how a patient personally communicates, having communication assistance for high-stake interactions, and having a preparation in place for a longer stay in a medical facility.
Going off this, some other strategies found in Article 2 that SLP specifically can help with our expertise to make communication between patients and healthcare providers better is emphasizing taking the time necessary to communicate with patients and waiting until the message was understood. Also looking for physiological or nonverbal cues from the patient. As SLP, you can kind of help healthcare providers know what to look for to ensure that they're getting the message from their patient. And also just emphasizing to healthcare providers that they should ask for help, either from family members who might be better at communicating with the patient or from speech language pathologists, as we can provide strategies to help communicate with the patient.
Okay, Article 6 talked about how currently poor patient provider communication in hospitals continues to be cited as a possible causal factor and preventable adverse events for patients with severe communication disabilities. And it gave several core strategies to help improve communication in the hospital. One of them, devoting enough time to communication. One of the patients said that one of their good nurses was one that took time to communicate and speak directly to them. Another one was develop services, systems, and policies that support improved communication. So having the hospital put those services and systems in place, and to also ensure adequate access to communication tools. So that patients with more complex disabilities often lack assistive technologies or adaptive equipment in the absence of AC. Leaves a patient relying on carers to communicate and leaves them with no way to communicate themselves if they're not there. And another strategy is to increase the communicative competence of the hospital. So that's our job as the SLP, to educate the staff and the parents and patient why AAC is important and the importance of communicating. Also in my article, it looked at researchers that were in the field of AAC. They gave recommendations to improve communication in the hospital, and some of these recommendations include instigating training and education on disability communication AAC, and also increasing awareness of the patient's need to and ability to communicate, and of being equal communication partners, as well as revising hospital systems and policies to support implementation of AAC strategies.
So in Article 3, it talked about using the participation model for patient-provider communication. And to do so, it requires using strategies like we've talked about before. So Article 3 talked about how currently there's some generic pre-made communication supports that are in place, but we really need to think about these supports because they may not include specific content that an individual needs. They might not really have the information about an individual's daily routine, or they might be too difficult for a patient to use, or it might not even be accessible for a patient to use due to some fine motor deficits or other deficits. So this brings us to our pink theme, which is prioritizing the patient as an individual. So just a review of the participation model, as we know, it talks about how we can use AAC assessments and design interventions that are based on functional requirements for participation in life activities. So really looking at that patient as a person. So therefore, personalized patient-provider strategies should be incorporated. So this can look like personalizing messages on communication supports, or personalizing access and layout for a patient, or personalizing the messages and the way they're represented. So for example, for an adult patient, we probably don't want a like cartoon drawing. Instead, we could use something like photo images that are relevant to them. Some other factors that we need to consider when we're really thinking about the patient as a whole. As SLPs, we can think about the patient's age, their needs, their skills, their level of recovery, their preferences, the knowledge of the staff and that will be helping these patients, and the availability of the materials, and how that patient is going to travel across the continuum of care. So we really need to consider this when we're looking at how we're going to support these clients using AAC. So in Article 4, SLPs used a focus group and data was collected, and SLPs discussed common concepts during the study. And one thing that they all talked about was SLP attitudes, and how they really wanted to place an emphasis on the importance of not making assumptions about patients' abilities or about their priorities. So looking at their levels and not assuming that they won't be able to use a certain device, but also not assuming that they're going to prioritize photo images when maybe they might like cartoons.
So yellow is the need for more training for both SLPs and other medical professionals. So Article 2 looked specifically at nurses and their interactions with patients, with communication and the use of AAC. And a big theme here was nurse-patient communication is critical to quality care, which seems quite obvious, but then on the opposite side, nurses typically receive little to no training in how to use AAC with patients who may have complex communication needs.
So going back to Article 4, these SLPs in their focus group also discussed common concepts, such as how limited AAC resources, knowledge, and training are often found in their settings. And so they really talked about how it is important to provide AAC at all recovery levels, and how limited expertise can really impact this, as well as the feasibility of having a dedicated AAC team in all these settings, and how it's so important to have this AAC training and really get the individuals who are using these devices with their patients training, whether it's the SLP or other medical professionals. And then another thing that was talked about in Article 4 was really the importance of using a team approach. So like I said, the SLPs working with those medical professionals that are in their setting to have a team together and discuss and communicate with each other as a team how a patient is changing and how maybe their AAC device needs to change with them.
So Article 5 discussed the importance of developing AAC strategies while still preserving the caring ontology of healthcare professionals, their professional pride and competence, and this all in turn leading to better care and more communicative patients. So healthcare professionals can play an important role in promoting AAC, but further education, training, and follow-up are needed. So this is where SLPs really come into play. This is our area of expertise. We can provide education, we can provide training, and we can provide helpful follow-up to healthcare providers to help them better efficiently communicate with their patients.
So
So
our
these-
green theme talks about the need for more research. So Article 1 talks about how AAC professionals can address communication barriers by continuing research on the usability and impact of AAC strategies in medical settings, and also continuing research on non-speaking patients in hospitals in general. So there's research out there, but it needs to be continued.
In Article 6, the one that gave different strategies to help improve communication. Unfortunately, there's no reports or trials to validate any of these strategies in the hospital settings. So definitely research is needed to investigate the validity of these strategies that are proposed to improve communication.
All right. Article 7 looked at the experiences of patients and providers during conversation. And they found that a lot of research about communication is mostly about factors such as trust, respect, and empathy, but it doesn't really focus on actual communication in AAC. There's also a lack of knowledge about the experiences of patients and providers in the ways that they overcome communication breakdowns and use strategies. So we need more research on this. And then AAC for a lot of providers is often seen as a last resort, and professionals are often unaware that AAC can empower clients and patients to be more involved in conversations. And this is another area of research that we need to look into.
So purple looks at patient-provider experiences. So in Article 2, when they were looking at the nurses with their patients, nurses reported that lack of communication they thought was affecting overall patient recovery and their length of stay in the hospital. Patients reported feelings of frustration, lack of control, physical discomfort, and overall effects on recovery when they're unable to communicate with nurses. They also felt their basic care needs remained unmet, and carers of this patients worried that their this person would be at risk of being neglected, ignored, isolated, or possibly injured secondary to ineffective communication. And all these perspectives are things that can be fixed through the use of AAC and integrating more communication from the patient through AAC.
All right, going back to Article 7, they kind of found 7 key themes regarding the experiences of patients and providers. So clients often blame themselves for miscommunications. Both clients and professionals found that it was important to prepare the conversation beforehand, so to write down kind of what they're talking about, so everyone, to make it more structured. They both found that a calm and quiet environment without distractions is important. Clients felt that they often did not have enough time to express themselves, and that providers completed their sentences for them. Clients stated that they use a lot of nonverbal communication to express themselves. However, professionals stated that nonverbal communication was often complex to understand due to a lot of these patients' physical disabilities. They couldn't quite read their nonverbal communication. Clients appreciated when professionals repeated information, spoke slowly, used simple language, and found that they often used difficult words, talked too fast, and gave too much information. And then they also found that there was a lack of AAC used in these long-term facilities, and a lot of professionals had negative attitudes about AAC and felt that it wasn't that important.
Going back to Article 5, looking at healthcare professionals' perspectives on AAC in critical care settings, they really found 3 themes: that professionals had this caring ontology, which was a foundation of their profession. They wanted to care for their patients, and they perceived communication as a core of this caring ontology. And then that transitions into their cultural belief, this theme found in the article, which is this biomedical paradigm that for healthcare providers, saving lives and treatment came first, and that they didn't prioritize communication in relation to this. So then this then resulted in the triggered context, which was they were giving low priority to psychosocial issues like communication. So this is something that, like, us as SLPs, knowing their beliefs and why they aren't using AAC, we can go in and address this and emphasize the importance of communication in addition to this care that healthcare providers are given.
Okay, so the orange theme looks at the complicated logistics of incorporating AAC and why there might be access difficulties. So a quote from Article 1 really summarizes well that there are difficulties out there. So it talks about how in an ICU setting, 91 patients daily average who are conscious and over the age of 3 years old, 33% were unable to access the nurse call system, 33% were unable to use their speech, and 19% could not do either. So this really just shows that AAC isn't being used. So in Article 4, SLP discussed reasons for this not being used, and it included that there are complicated logistics to incorporating AAC. So some reasons for this include time constraints, funding for AAC services, looking at the continuum of care in the rehabilitation setting and how they might not be receiving these services in other areas, and looking at limited AAC policies and how they might not be in place in certain settings.
So in Article 2, some of the barriers found here of why AAC was not implemented was that the communicative interactions between nurses and patients were task focused, nurse controlled, and it was mainly focused on the physical needs and medical care procedures. So we can kind of reflect back on the article I was talking about before with the biomedical paradigm, that their main focus is addressing the physical needs of the patients, and communication is not always prioritized. Additionally, this article found that some nurses view patients as having no real need to communicate, again, associated with that idea that their main focus is to provide care of those physical needs of the patient. Additionally, there was limited access to AAC, and a major source of difficulty in the nurses' communication was, again, just going back to that lack of AAC knowledge and training, which is really where us as SLPs can come in and help to mend that gap.
All right, so in summary, we found some contrasting information across articles. So we found that there were varying perspectives from healthcare professionals in regards to how they value AAC and how important they think it is. Some professionals found that it was a waste of time and it wasn't that important. And they viewed other care factors as more important. And a lot of professionals used it as a last resort. And in some articles, some professionals found it to be very beneficial. So there's differing opinions about AAC. How can we apply this information clinically? Part of our role as SLP is to educate others on the importance of communication and how we can implement AAC to support communication. We also have a role to use strategies and to help other people use strategies that support communication between individuals who use AAC and other healthcare professionals. And this is important because it contributes to their quality of care.
Okay, what else should we know? Currently, we know that AAC can enhance the quality of care in patients. However, many healthcare providers are not educated or don't feel comfortable in implementing AAC, and they don't understand the importance of it. And also, us as SLPs, we play a very important role in educating and facilitating the use of AAC in the hospital. And also, there's just there's research, but there's much need for more. And what's missing from this research is specifically further research is required to explore patients' experience of being able to communicate with it, and just the lack of knowledge about the experiences of patient providers and the way they overcome communication breakdowns.